Do. Let's do. It's always hard to find when I first jump into the group. Are we live yet, Ruben? There we are. Okay. Awesome. Welcome in, you guys, officially to night 2 of the 3-day EKG challenge. I can see now we are live on Facebook. Thank you, Ruben. I'm going to hit record, so just in case we have a issue with anything, we have a backup. And then sounds like you guys are good to go with the workbook, so that's good. So I have a great announcement, and that is if you were here last night, we talked about the little kit, the prize, and we have a winner. I'll be announcing in just a minute. I'm hoping to see if this person logs on. Yep. Okay, awesome. Hey, Kakisha, and we have Matt in the house. What's up, Matt? Melinda McCoy. All right, perfect timing. Okay, well, let's go ahead and kick it off and get started. So this is the night where we learn the arrhythmias. And if you struggle with solving them, we're going to kind of just keep it very basic today and stick to just talking about them, showing you them. We're not going to quiz you on them. It's just going to be super low key and mellow. So really easy, really chill. And yeah, doesn't that sound great? Just nice and mellow. Hi, Matt. So this is I think we might have spelled your last name wrong, but Melanie, you're the winner. That's why I was waiting for you to log on. You actually are the winner of the kit. So, Melanie, you got to send me your address. And that way I can get this in the mail to you because you won the kit from last night. So I know, right? Isn't that so cool? So congratulations. And then also, I'll be mailing that out to you, of course. But just send it to me in Facebook Messenger, your address. It'll be a lot easier. And then also, before we go through this, we talked about, I don't think we talked about this yet. This was the homework for last night if you wanted to do it. We'll go through the answers, but I wanted to also just tell you that more prizes are coming. We have some prizes at the end of tonight that I'll be giving away. And then tomorrow night, we're going to be giving away the scholarship to our 30-day EKG challenge, which starts on Tuesday of next week. And so far, I am literally impressed with, there's like 5 people that are in the running. I listed your names in the group this morning. 5 people that are in the running for the scholarship. It's not too late. You guys can still get in the running. And as I mentioned last night, in case you weren't here, the way to get in the running for the scholarship, to have a month-long free pass in our 30-day EKG challenge and the EKG Launchpad, which is all basic. How can you win? Well, we're looking for people that are lifting their fellow coworkers, or not coworkers, students in this challenge up, helping them if they don't understand something, or encouraging them if they answer. If that person is not having a good time finding something, helping them, but just basically really encouraging each other, because we're fostering an environment where we are all on the same team, and by sticking together, we can learn it better. So I want to reward the person who does this the most, of course, genuinely. And so far we have like 5 people in the running. So if you want to give me a bigger pool to pick from, I will not be disappointed, but I'll be announcing the winner tomorrow night on our live. Okay, so let's get into it. Yes, it's very cool, and judgment-free zone, that's what we love. Exactly. Okay, so if you, like I said, got the workbook in your messenger and printed it out, and you were like, I'm going to go ahead and do the homework, these are the answers. A lot of you were asking me last night for the answers, but I wanted to give you a chance, if you wanted to try on your own, to see how close you got. And this is not a test, of course, but it's fun, right? We talked about this yesterday. We definitely talked about the P wave, that it means atrium is contracting. We talked about the negative, right, deflection of the QRS. And if the Q wave is less than a third the height of the R wave, it can be normal, unless it's in V2 or V3. The QRS, we talked about, represents ventricular depolarization. We went through all this last night, and you guys were complete rock stars. I don't think you needed practice on this at all. And then also just talking about the R wave was the first positive deflection. And then the T wave, we described that it should be round and should be upright in all the leads except for AVR and V1. So that was the answers to those questions. And KJ and Matt are here. You guys are gonna just like fall in love with Matt and KJ. They literally just, they're our biggest cheerleaders, your biggest cheerleaders. And it's pretty magical what they've created here. So I'm just honored, just honored. I don't know what else to say. Here's more. There's a second page. So there was 2 pages for night 1. And we talked about the fact that the U wave, remember that wave at the very end, which wasn't supposed to be there, can mean hypokalemia. We talked about the delta wave, that it has a short PR interval. And we talked about that mnemonic, right? WPW, what it stands for. How to measure and the amount, right? 120 to 200. The distance, we talked about the ST segment that we're looking for elevation and depression. And then all the things that can cause ST depression, hypokalemia, cardiac ischemia, and medications such as DIG. And then QT prolongation can lead to torsades. We talked about that. And then regular versus irregular leads us right straight into tonight, where we're going to talk about the arrhythmias, where this really matters. All right. Sweet. Can I put them in my pocket? I know, right? Literally. And you made a note about the biphasic. Oh, Crystal, I love that. Okay. Good. You guys are making me all warm and fuzzy. All right. Now, speaking of warm and fuzzy, if you really want to solve the arrhythmia, these are the 3 things you want to ask yourself. And this is 3 questions I ask myself literally every day when solving them, when I'm looking at these strips, right? And the first thing, is it narrow or wide? Because if it's narrow, we know it's coming from above the ventricles. If it's wide, it's coming from the ventricles. Of course, unless it's like, hyperkalemia or something that's making it wide, then that goes out the window. We also need to know, is it fast or slow? And is it fast enough that we need to grab the adenosine? Is it slow enough we need to grab the atropine? Or do we have time to sort of ferret things out? And then we're looking for the regular versus irregular. And we talked a little bit about that last night, looking at the R to R. So let me just point that out on this EKG, which is totally not meant for teaching, but just because it's here, we'll just play with it, because why not? Why not? All right. So here, from here to here, this is the R to R interval. You can see on this EKG, the R to R is nice and regular. That's what we want, okay? And there's a P wave before every QRS. That's also what we want. This would indeed be by rate and by width, and by the PR interval would be a normal sinus rhythm. And this is what we want to see, okay? So moving right along, then we're going to talk about things that come from the atrium. Now, there are lots of things that come from the atrium, and they just basically, it depends on the rate, and it depends on who's driving the bus, so to speak, okay? There's even more than that, basically. Oh, you just gave atropine to a bradycardic patient. Melanie, that's awesome. That's so fun. I miss being on the bus. So all the things, right? Flutter can come from the atrium, going to be narrow complex usually. AFib or AFib with RVR, SVT, supraventricular tachycardia, sinus tach, WPW, PACs. Those are all coming from above. Although what's interesting about Wolf Parkinson's White, that it'll make a wide QRS, which will be confusing. And you'll think it's coming from the ventricles, but it's not. So this is the one you got to keep your eye on, because he widens the QRS. Remember that? And so we got to keep an eye. But then this rhythm at the, at the very bottom, this one is something that I see every day at work, every day. So anyway, yes, racing down the road with success the first time. Wow. Oh my gosh, you make me miss it. Oh, okay. So what is this rhythm right here? First of all, we know it's irregularly irregular. Second of all, the QRS looks a little bit wide to me. This is computer generated, so we'll just say it's narrow. And there's no distinguishable P wave. So we know that this is indeed none other than yes, AFib. Good job. Hey, Stephanie, what's up? And yes, Crystal, I do think it looks like a little wide there. It's not supposed to be, it was computer generated, but good eye, like super good eye, Crystal. And this is AFib. So the rule is that if you look for a P wave and you can't find one, then that's probably AFib. Okay, if you're squinting too long, it's probably atrial fibrillation. There's also going to most likely be a star in the PR interval on the 12 lead. Now let's talk about this guy here. This is what we hope to see. And this is our beautiful normal sinus. See, Stephanie, you're getting it. Stephanie understands. I'm loving this. I just can't, guys, I can't even tell you. You make me so happy. So anyway, this is normal. And let's really check it out because let's make sure that our R to R is the same distance, and it is. We could use calipers, and fortunately I don't have calipers on here. Crystal, I would say this looks a little wide. It's not supposed to be, again, computer generated, but we'll say it's narrow enough complex, and it should be 60 to 100, which this is. How could you figure it out? Well, you have a couple different ways. If you have one of these badges, I'm going to be giving a couple of these away tonight, by the way. You could use the red marks to measure, or you could do it the old-fashioned way and just count, right? You could do that. You could count. So anyway, looking for 60 to 100 normal sinus, we always want the sinus node to be in charge. And when the sinus node is, it makes a P wave, and sinus node makes P. We always say that. Now this one's really fun. This one is super fun. Okay, yeah, exactly, Melanie. Consistent P waves before the QRS. Exactly. Love it. Okay, so then we have this rhythm. And this one is often mistaken for AFib because it's a little bit irregular. And so people are like, well, I don't know, it's irregular. So it's probably AFib because we're like hardwired, programmed, irregular AFib. But the thing is when you go look at it, you'll see that there's clear, distinct P waves. You can see there's one here, there's one here, and the distance is the same between the P and the QRS, okay? So there's no heart block, there's no different morphology as if we might be seeing in a wandering atrial pacemaker, but there definitely is a measurable distance issue between the R to R. It is not regular. That is short, that is long. So right there, we have a mismatch. So what do we do with that? Well, what we do with that is we got to know that we would run a longer strip to really figure it out. Oh, right on. Look at you guys. Respiratory related, Matt. Yes. You have calipers? Okay, Crystal, I just got calipers. Like literally finally broke down and got calipers. I know. I'm because all my EP people that I work with are using them, and I have to fit in with the nerds, right? I have to be an EKG nerd. Okay, good. Yeah. So is the drop beat with inspiration? Yes, this is caused by by breathing. And this is called actually, this is called sinus arrhythmia. And it's very normal in young people who are very fit. It is unlikely that you are actually dealing with sinus arrhythmia if they are older, but still possible. So the age really matters. So that's basically sinus arrhythmia. It just gets confused for AFib a lot. And then going down to this one, this is a sinus bradycardia. And oh, Crystal, you are so astute. Oh, are you trying to follow the worksheet, Crystal? Because there's only 4 strips on the worksheet, and this has like a lot of strips. So that's probably what's going on. You have 4 practice ones too, but there might be they're pulled out of here, so there might be some similarities if you're noticing that. Okay, so yes, Melanie says pacing, atropine if necessary. Okay, absolutely. And so, do they have a pulse with this? Hopefully, right? They're pretty slow. But there's definitely a P for every QRS, and the R to R is nice and regular. And basically, how can we cause this? What do you guys think? Beta blockers, exactly, Crystal. What else? There's 2 other things I can think of off the top of my head that can cause this in the medication realm. I know Crystal is on fire. Like, seriously, where's the fire emoji? Opioids, yeah, if they overdose. Calcium channel blockers, where have you been, Kakisha? Yes. Or it also says that, and an OD, yeah, for sure. And there's one other one you may not know, but an antiarrhythmic drug. So like amiodarone. Oh, there is a fire emoji. Oh, it did too. Yeah, that's possible. Magnesium. Yep. Magnesium really can lower your blood pressure, actually. And magnesium has a lot of good things about it. I could go on and on about magnesium. In fact, I just did a podcast today. I was a guest on a podcast. If any of you follow on Instagram, Real World NP, I don't know when she's going to release it, but she had me on as a guest and we talked about magnesium today. So if you, when it comes out and want to listen to the end of it, I talk about magnesium. But anyway, yeah, the first thing for this is we're going to go look and like make sure that this is actually, what's going, is it fixable? Is it reversible? And if so, let's reverse the thing. Let's get rid of the offending medication. Otherwise, we're, at some point, if it's non-reversible and they're symptomatic, we're thinking about putting in a pacemaker. Okay. So what is the rhythm? Here's another one. This is the same thing, but just faster. So what would we call this one? Wow, Crystal, you're just a wealth of information. Oh my gosh, KJ, IJ account is not nerdy. It's like so cool. All right, yes, good. Crystal and Orit both got it, and so did Melanie. Crystal, you're never too old for IG, actually. They found the demographics are actually a little bit older than the TikTok demographics. Yeah, and I do have both, so maybe I'm just like the super nerd. But anyway, so this is sinus tac. What can we do to cause? What can we do to cause it? Oh, and by the way, she says way too old for TikTok. So I will tell you that I've actually learned some things on TikTok. It's not just dancing, like there's actually really some good information on there. And I know it's crazy. Okay. Let's see. Caffeine, exactly. Mm-hmm. Cocaine. Mm-hmm. Exercise, stimulants, fever. You guys got them all. Like, really, this is awesome. Stress. Did anybody say pain? Pain's also one. COVID, but let me tell you the one that's most important. Even, and I agree, sepsis, right, Melanie? I like where you're going with that. The most important one, and yes, Caitlin. Hi, Caitlin. I'm glad you're here. I just messaged you like right before we hop on. PE, okay? If you can't explain why a patient is tachycardic, you have to think about PE. Always think about PE. Okay. Good morning. Crystal went from caffeine to cocaine. Hey, she's covering all the bases. It's actually nighttime where I am. Okay. So what is the rhythm here? This is a fun one. What is the rhythm? It's regular, but it doesn't have P waves. This is exactly atrial flutter. Good job, KJ and Crystal. And the waves, these are called, does anybody know? These are called I'll take two names. F waves or also sawtooth. Yeah, good, perfect. And the deltas are a little different. The deltas are the slurred upstroke, and they look like, and forgive my like very not good drawing, but it's like a widened slurred QRS. So they're a little bit different, the deltas, and they come with the WPW. Yeah, sawtooth picket, exactly. All right, good. Oh, side note, flutter, I feel like flutter is AFib's stubborn cousin. Do people have the same stroke risk with AFib as they do with atrial flutter? I mean, do we have to think about stroke? Absolutely. Good. You guys all knew that. Perfect. I love it. All right, let's keep going. So, this is our AFib here. And so I wanted to kind of run through really quick, taking notes in the chat. Tell me what you've heard a patient complain of who has AFib, because this list is going to be long. Okay, so let's start it out. It's more productive cousin. I'm a stroke nurse 100%. Oh, Caitlin, that's awesome. Butterfly, okay, shortness of breath. Love it. Oh, I was supposed to be typing in my box. Dizziness, yes, lots of people saying dizziness. Fatigue, good one. Butterflies. Oh my gosh. I can't spell today either, huh? Look at that. Um, okay. Palpitations, absolutely. Has anybody ever heard somebody say they just don't feel right? I've heard that, don't feel right. Or there's two other things that I hate when I hear my elderly patients say. They'll say, well, actually, I've heard them say, I'm just out of steam. That's one, because they're losing their atrial kick and potentially their rate's high. So they're like not really perfusing. But I've had like more than one female say they have confusion when they're in it, but they're on anticoagulation. So it's not because of a stroke. So just a really weird thing. And you've heard it with strokes too. Don't feel right. Yeah, exactly. Heart skips a beat. That's impending doom. Hi, Paul. Where you been, Paul? So yeah, good. These are a great list. Thank you guys for contributing to my AFib list. All right, good. Let's do the junction. Now the junction, that's when basically the AV node decides to take over the heart. So the sinus node isn't doing a good enough job. Either they have sick sinus or something else has happened, but the AV junction had to step in. And it's sort of like the vice president of the heart. You don't want the AV junction to kick in, right? You want the sinus. But what you're going to be missing in these junctionals is you're going to be missing, of course, the P wave, because as KJ said, sinus makes P. All right, good. Well, I'm glad you're doing okay, Paul. Glad, glad, glad. Okay, so this rate is between 40 and 60. We still have regularity. Again, these are narrow, even though they look a little bit wide. They're narrow, complex. So we know that the AV node is in charge of the heart. And the key is just really picking up that there's no P wave here. Should be right here, should be right here. And, the big question is what to do about this. So you want to make sure it's not from ischemia. That's the big thing. And, a lot of times you'll see this when people are in reperfusion, but it'll be faster, it'll be accelerated junctional. And then it gets really confusing because you're like, well, is that sinus? Or, what is it? And it turns out that it's just fast and it doesn't have a P wave. So the P wave really comes down to settling the bet on who's running the heart. And so a lot of times underlying cause, Melanie, right? So let's get a CBC and CMP. Let's make sure that the electrolytes are okay. Let's check a MAG. Let's make sure they're not on any rate limiting agents. And if they are, let's take it off. But I do like Melanie. I was just talking about this ad nauseum today. So I love that you said it because off topic, completely off topic. I just actually on that podcast was talking to Liz and she's like, do you have any like advice for new providers? And I was like, yes, I do. My advice is that if you have somebody with a problem, whatever it is, chest pain or high blood pressure, hyperlipidemia, anything, ask why. Ask why. Because we are not supposed to just like put medicines in people's hands and be like, okay, right? And like they're on 4 medications and nobody even thought about sleep apnea. So, the same thing is true for the tachycardia. You have to ask why. And in this case, we'd be asking about, the underlying cause and thinking about it. So, yeah, SA node disease, exactly, Matt. Exactly. Yeah, Caitlin, it is like being a detective, and that's what's so fun. And KJ, I know you're big on treat your patient, not the monitor. I know that's your big draw your lines and treat your patient are KJ's mantras. Like you will always hear KJ say that. Okay, let's talk about some ventricular things. So ventricular things, we could have some real badness here. Now we've transitioned into the wide QRS now. So basically you've got this slow rhythm, but it's still regular, but it has a wide complex over 120. You may or may not have a pulse with this, and this is known as idioventricular rhythm. Okay, idioventricular rhythm. We could be PEA if they don't have a pulse exactly. And in this case, really, they're probably not going to have a pulse or they're heading towards it. And sort of, in medic terms, we used to say they're circling the drain, get them out from the drain. Because it's like, yeah, all Hail Mary, let's fix them. They are not going the right direction. And then unfortunately, this is kind of where you either terminate in VTAC or VFib or asystole or this agonal rhythm. And this is sort of when all of the guys above, like the sinus, the AV, and then the bundles, they all gave up. They're like, we're done. Then the little lonely heart cell at the bottom of the heart is trying to run. And he's so tired. He has a band-aid on because he's like, I can't do this. I can't run the whole heart. And it's unorganized. It's very wide because it's not doing the job, right? Um, yeah, poor little lonely heart cell, exactly. And hopefully you never see this. Hopefully, right? But then there's a couple things that we absolutely have to know that I call sight rhythms. So let's run through those real quick because there's three of them. So as soon as you see it, as soon as you know it, tell me what it is in the chat. All right, let's see. Oh my gosh, Melanie, you're out there saving lives. Look at that. VTAC, good job, Stephanie and KJ. Caitlin, everybody says VT. Jennifer, Melanie, okay, love it. There's no argument here, right? I'm praying every bit of the way. Oh, I love it. If you also said that this was a wide complex tachycardia, you would not be wrong because it is a wide complex tachycardia. If you wanted a 12 lead to really say what it is, then you could. But yeah, Snarfly, what's up? Snarfly's on Facebook. Been a long time since we've seen you. But yeah, this is VTAC. Okay, good job. Let's do the next one. Ready, set, go. What one is this one? VFib. Woohoo! Yes, you guys all got that. Yes, strong work. This is VFib. We would actually defib them, Edison medicine, as Coach Sean always likes to say. But good job, everybody. You guys are nailing this. And then, of course, this is like anarchy. There's no pulse, right? And then, of course, you also want to know about asystole. I didn't even put that in because I was like, everyone knows asystole. Yeah, no problem. Okay, now lastly but not leastly, we're going to just talk a little bit about a couple of things, and that would be the ectopy here. Okay, so what kind of things can cause ectopic beats, extra beats? VFib gets the defib, exactly, Matt. I know, great group effort. That's because KJ and Matt, you guys are leading it. I love it. Ooh, Melanie, actually pacemakers. Okay, I know what you're thinking of. So when a pacemaker is in a demand mode and then it kicks in, it can cause a beat that looks like an extra beat, right? Um, but you would see pacer spikes, exactly. And there's no pacer spikes here. So, but what kind of things that could cause it? I know, me too, Matt. Okay. And these are, by the way, PVC. So electrolytes, or yes. And specifically, actually, believe it or not, hypokalemia for some reason seems to cause a lot of ectopy. So you want to definitely get a K and a mag for sure. Pregnancy can cause them. Absolutely, Haley. Hello, Haley. Caffeine for sure. Yep. Thyroid storm could cause that or tachycardia. So when you get a TSH. Ischemia, right, could cause ectopy. In fact, when people are on treadmills and they develop ischemia, then that's always, or sorry, PVCs, that's always like a warning for us. We're like, ooh, we better consider capping this patient. So yeah, all good answers. And anxiety can cause them, exactly, Paul. But these are noticeably different in the same strip. They're a different morphology or shape. And we call that something. So if they're all the same shape, we call them unifocal. The thyroid disease would be hyper. So, but it's backwards because the numbers are low. So thyroid storm would usually cause tachycardia or PVCs. But yeah, unifocal is, they look the same. Thank you. Looking the same. And multifocal if different. But what does that really mean? It means that, so different morphology. It really just means they're coming from a different area because the camera, right, is in the same place and the extra beats are coming up, right? And they're coming from different areas. And that concerns us because that means that potentially the heart is more irritable and there's more affected area that's ischemic if that's what's actually going on. So goiter, yes. Yes, goiter, always you think about thyroid. And here's the interesting thing, Millie, since you're curious, I'm just going to answer because I love talking about it. You in thyroid stuff, you really just like the hyperthyroid will cause the goiter, but eventually with all thyroid stuff, if you're hyper, you're going to burn out and go hypo. And then sometimes when you're hypo and we over medicate you, you can go hyper. And it's just like this vicious storm. So goiters are really rare these days. Because we usually correct and fix, so they never get a goiter. Goiter often seen in like third world countries. Although I did see a goiter on somebody in cardiology who was having palpitations, and I was like, yes, it is a constant battle. You're right. So yeah, it's insane. But what's interesting about the thyroid is that we're we're medicating it, but not really fixing the underlying problem. Again, we're not asking why. And it is a fine line, yes, because ultimately, a lot of thyroid disease is autoimmune based. Your own body attacks the thyroid tissue, causing things like Hashimoto's. You've heard of that, right? But yeah, it's crazy. I'm sorry if you're not interested in thyroid, but oh yeah, how does thyroid radiated due to hyper? Yeah. So you're loving the thyroid stuff too, Melanie. I know, I can tell. Okay, so remember, you have the workbook. We went over the first two pages. There is another page in there that's on arrhythmias. I'm not going to show it to you because I put the answers on it accidentally already. We already covered this VTAC, right? We covered, oh, we didn't cover this. What's this? What's this? Oh my gosh. Yes. Yes, absolutely. Run a VTAC, KJ, exactly. Yeah, Crystal, you're so right. They usually have a friend or two. Mm-hmm. Yes. And yes, 100%. Non-sustained VT, Jennifer, good. VT, good. A disaster. That's funny. Totally. But we would document this. I run a VTAC. A call from Telly. Exactly, Caitlin. Oh my gosh. Story of my life. Okay, anyway. What about this one? This one's easy. It's a piece of cake. Flatline. Yep. Okay, we got that. That's like a piece of cake. And then we talked about this one, anarchy. But what about this one? This one's a little more challenging. We didn't cover it. A little more challenging. Saving the good stuff for the end. Hmm. Picking along. And then back into something else. So yes, this is SVT that resolves spontaneously. Yes, so we would call it PSVT, paroxysmal SVT. So good job, everybody. So regular and fast, and then converts back into sinus where you can see that beautiful P wave. Okay, good. This one, it's not meant to trick you. This is also the computer generated one, um, computer generated rhythm, but we have beautiful P's. And it really comes down to getting out and calculating your heart rate. And this is what you can just tell from your eye looking at it, it's a little fast. This is our garden variety sinus tach. And we need to make sure that we're not missing, I know it looks like cursive. It looks like art lines. Melanie, you're cracking me up. But yeah, this is sinus tach. Remembering we're looking for the Y there. And then this is an actual case. And not that we're going into 12 leads tonight, but you know me, I just can't resist. If you've been hanging with me, you know you're not going to get through an arrhythmia class without at least one EKG. So anyway, this gentleman comes in, he's in his 30s, and his mom is a nurse, and she tells him go get seen by cardiology. So patient has a heart rate of 47, and his Apple Watch keeps telling him low heart rate. Come on in, right? And I love those Apple Watches. You know, they're usually pretty correct, actually, believe it or not. And so anyway, KJ spotted something, but the T waves are not behaving. That's true. I would agree with you. And literally, when we talk about the T waves tomorrow, I'm going to think about this EKG because this is where it's at, right? The T waves are awful big. Remember we talked about the mom dad baby situation and how the baby shouldn't be very big. Well, this, I would think about hyperkalemia, right? His K was actually normal. With thinking about hyper K, we would also get a CMP, making sure his renal function is normal. It was, but the T's are tall, right? We really can't explain that. And we're worried about that. And they're diffuse in multiple leads, right? Not just in one distribution, which we haven't really talked about. But anyway, so in the meantime, let's settle what the rhythm is, and then I'll tell you what happened with the case. So you've got down here, this is what rhythm? We've got, well, yeah, we thought there was electrolyte issues, but the potassium was fine. And it was a sinus Brady. Good job, Crystal. Get that fire emoji out for Crystal. But it was sinus Brady. And I think I saw KJ already allude to it earlier that yes, there's some T-wave jail subjects. Exactly. Oh my gosh, you're cracking me up, Matt. So yeah. Anyway, so this is a sinus because we have a P, we have a QRS, right? And it's consistent and it's 47. So technically this is sinus Brady, but the question is, what's the question you got to ask this guy? What's the question? I know, seriously, we have some very, yes, Crystal, again, look at you. That's the right answer. How do you feel? Exactly. He says, I feel fine. And he says, no, I'm not an athlete. Yes, welcome, Kakisha. He says, but I go to the gym in the morning before work for half an hour, and I go after work for at least an hour every day. We're done here with the heart rate, right? He's not symptomatic. He's super fit. And then, yes, asking about history of cardiac issues. Yes, does anybody need a pacemaker? I like that. Asking about, potential ACS questions in the family or CAD questions, yes. But we ended up, because of the T's, they really worried me. We ended up doing all the things anyway. We did an echo, we did a stress, we even did a calcium score because I was like, those T waves, I've never seen T waves that look like this that don't have something bad behind them. But I also showed this case because that guy had a completely stone cold normal workup and his T waves were normal. So that brings me to a point. Why would I include this in tonight? Well, first of all, I've been experiencing some crazy things lately, and it's kind of shaking my foundation. Yes, and what I'm seeing is I'm seeing some EKG findings that are not really lining up to what I'm seeing when they go to the cath lab, for example. And I'm just like, what? Like it's rocking my foundation. So this started my journey of realizing that the EKG gives us clues, but it's not always right. Just know that, okay? That sometimes you will be like, no, I would have slam dunked that this is a PE. This is all, it was none of those things. But would we still worry and refer to cardiology? Absolutely, right? Or even to the ED with this EKG and the Brady. Would you be wrong going to the ED? You wouldn't be wrong. All right. So anyway, I digress. I have so much fun telling these stories. Okay, so it's prize time. Woohoo! All right. So what's the prize tonight? The prize tonight. Well, honestly, I think the prize really was I got the prize of getting to hang out with you guys and watch all of you interact and get to know each other. Best gift ever, seriously. Anyway, okay. So this is a prize. I think I showed you guys this earlier, yesterday maybe, our cat badge. So we're going to give away 2 of these tonight. I'll be giving away tomorrow. And I'll be picking 2 winners. So how can you win? Well, you're not going to do anything. I'm going to do all the things. I'm going to go back. This is what I did yesterday. I'm going to go back and look at all the things in the texts, in the text feeds, and I'm going to pick the 2 people who interacted the most, and then I'm going to announce the winners tomorrow, and we'll be mailing these out to you. These are so cool. We love them. I literally have them on every badge wherever I work. But yeah, anyway, so yes, we had a lot of action in the chat tonight, which thank you for that. I hope you guys are getting to know each other and getting to like bond. That'd make me happy. And hopefully you feel more comfortable with the Rythmns after we went through them. And we kept it short and sweet tonight, right? So tomorrow we're gonna do basic 12 leads. And it does, right, Crystal? And you realize you're in such a supportive environment, like everybody thinks you're super smart. And yeah, right. So you get like gratification of knowing that you're on the right track because everybody's lifting you up and like, yeah, good job. So here, Crystal. And so anyway, tomorrow, basic Rhythmns, it'll be our last night together. Tomorrow we'll be announcing the scholarship winner to our 30-day challenge. That I know a lot of you are in it already, or have been in it in the past. And basically we're starting it up again next week. So if you're loving this, if you're like, well, I really like these people and I really like learning this stuff, I could actually maybe do this. I'll give you more details about how to join us tomorrow because there's some new options. So we sort of flip the switch a little bit on the way to join our 30-day to make it a little more accessible to people. So stay tuned for details on that. And then if anybody needs the workbook or the recording, we can get those to you. The recordings are going to be stored for all 3 nights on the same link. Ruben graciously uploads them for us onto a page. So they're going to be in one place. And so even this weekend, if you're like, ooh, I really want to like sit down and rewatch so I can take notes, you can do that too. So anyway, you're skipping date. Same Zoom, same everything. And we'll have our little goodbye party tomorrow night if you're not sticking with us. Otherwise, we'll be celebrating if you are. All right. So if you have any questions, don't hesitate to reach out to me in Facebook Messenger if anything comes up between now and then. And everybody have a good night. Sleep tight, and I'll see you tomorrow.